Good evening, everybody.
Good evening.
Nice to see you all.
Hello.
Hello. People are early and prompt. Joanne and Stephanie, Corey, nice to see you. Kurt, that's nice. This is great. Renee, I'm going to be sharing, various ones of us are going to share our screen today, so no problem with that, right? Perfect.
No problems at all.
Excellent.
Well, I mean, relative to that, I mean, I got 99 problems. Just that's not one of them.
I didn't leave room for that on the agenda for this evening, so I think we're going to have to just keep that for a different one. All right, so I'm going to give it 1 minute past 7. Don't start introducing yourselves in the chat yet, because you got an assignment when you introduce yourself in the chat. So, but don't worry, we're not going to play the Wordle. I still can't stop laughing about that one. All right, Liz. All right, Liz, you put your name in the chat. So now you got to make sure you add to this. I'd like you to just drop in your name, your practice, or your role at HP. And what's your favorite pick-me-up song? It feels like we all need to pick me up right now. So I'm thinking it could be an amazing playlist that we generate out of this. So just pop that in the chat. All right. Oh, Renee's already on it. She's already bobbing her head. A couple of you did that when I mentioned. So if you can introduce yourselves in there, we're going to go ahead and I think get started as you're doing that. Please pay attention to the meeting still while you're having fun with this. We're definitely saving the chat. We'll share out the good playlist later. Maybe I can get my son to make one and we'll share it out with you. All right. I'm going to share my screen to get us started. Just give me just a moment. You all see that fine?
Yep.
Okay, perfect. I will not be able to see all of your faces in this space, but I'm hoping that that will be okay. So if you're trying to get my attention during the meeting, please unmute, please shout. Just because I think we are using a number of slides tonight, we'll make sure we take the slide screens down and we can see everybody's faces. I love that so many of you are on camera already tonight. Thank you for that. It makes it so much better for those of us who are either presenting or hoping to get the dialogue flowing. So we got a bunch of things that we're going to do this evening. We're going to cover sort of a discussion about what models and what approaches you all are taking to behavioral health and care management integration in your practices. Bob Adams is going to walk us through the stimulant medication shortage again with some additional information, time for questions on that. We're going to touch base on the new HPV Start by 9 campaign, and then some optimization updates from Kevin Kelly on comprehensive developmental screening and bright futures. And then we've got some fun dates to think about our June pediatric PCP advisory meeting. You'll have to wait till we get that part of the agenda, but it's exciting. And then saving the date for clinical grand rounds. Lots of room in here for dialogue questions. So please feel free to unmute, participate as we go. So starting off, oh, lovely. My slides don't advance anymore. Oh, there we go. So why are we talking about behavioral health and care management and integrative models of care? Like, I don't even need to ask this question, right? You all know this. The mental health for children and youth in the US is just getting worse. It is not getting better. I know you all are living this in terms of within your practices, those who are in education, families working with their own kids. The numbers are kind of staggering. So you'll recall, it used to be that 20% of children, which was still a high number, had a clinical diagnosis of depression or anxiety. And back like 8 years ago or 9 years ago, anxiety didn't even fall on the diagnosis scale for kids, you know, in the top diagnoses. But now we're double the rate pre-pandemic. I put these two pieces of information on because looking at our local information, the Children's Agenda has been doing some really nice Monroe County parent polls. Now, this is Monroe County only. They haven't been doing it extensively across the region. But when they talk with parents who have children in the city of Rochester, 6 out of 10 are struggling with mental health issues. And these are significant mental health issues. 5 out of 10 in the suburbs. And then when that was a survey from 2022, when they repeated the survey this year, it was just last month that they released these findings, 50% of all parents, 50% of all parents are stating that they're concerned, significantly concerned about their child's mental health. So that's why we're talking about it. You are all living it. I know that. But what we thought would be a good thing to do is to think a little bit together about this, recognizing what we do have that's working well and how we might build on that. And so we really, this part of the meeting tonight, I'm going to frame it a tiny bit, and then I have asked a couple of providers to talk about the models in their practices. And then I would really like to have you all talk more too, or ask questions or dialogue around this. I don't expect to come away from this part of the meeting with like, okay, now we're going to do X, Y, and Z. But for all of us who are here from AHP, regardless of where we sit in the organization, whether we are in behavioral health or care management, whether we're, whether it's Mark Cronin or whether it's a medical director like me, we want to hear your thoughts about this, because this problem that's not going away and is only getting worse has to be a primary of focus for us. And we need to think about how to support the work in your practices ever more. So I just want to frame this out by saying, as with anything that we do, right, there's a continuum. It's not a one size fits all of how people address any kind of clinical problem in a practice. And this particular framework is it's a behavioral health integration framework that has been developed through Montefiore's health system under Henry Chung. This has been in existence and evolving for years, but it really helps to sort of capture the broad aspects of what you think about in terms of mental and behavioral health and how you can approach things. So if you look on the left-hand side, I'm really simplifying this. You could read the huge report on it, but I'm just simplifying it to give us context. If you look at the domains on the left-hand side, screening, referrals, both internal and external, quality improvement, evidence-based care, medication management and psychotherapy, self-management supports, and then social services links. You think about that, that really is a comprehensive sort of assessment of what goes into any level of care for someone when you're talking about their social, emotional, mental, or behavioral health. And then the strategies coming next highlight some of the things that you can see, some of the things you are already doing in your practices. Some of these are approaches that we're trying to support and in some ways decrease variation, sort of find best practices or best models with AHP. So if you think about screening, for example, the depression screening initiative is not just about screening, right? It's about how do you capture the data? How do you make it meaningful? How do you assure you're giving the right referrals? How do you give for people who are not even screening as positive for a particular condition, but they're at risk? What are the things you can do in those spaces? So think about, some of the work that's happening in that space. And then you could go through this and think about in our programs, how all of these things are sort of rolled out or how they're operationalized. But tonight, here we go again. I think it's not working. There we go. But tonight, we really want to focus around the referrals, both the internal, external referrals. So thinking about how do you collaborate with your care managers, but also what are the unique things that you all are doing in your practices with social workers or psychologists or other behavioral health providers within your practice or connected to your practice within the community. So we really want to talk about the local story, your stories. And just to frame this out one last little bit, I mentioned AHP care management. That is a central point of an integration model. Your care managers that work with you, many of them are here on this call. You just recently did some really nice assessment surveys for us. And the responses we received from you all were just so positive about the impact that the care managers have within your practice. And we recognize that in peds, with mental health and behavioral health being probably the #1 population health concern, our care management is very focused in that area. And that's why we have such a wonderful team of social workers with such high clinical skills and excellence in this area. But then there's other things that happen in some of the practices. We've got a practice that has an embedded psychologist we're going to hear about tonight. We have other practices that have partnerships with local mental health resources. They may be hospital-based or they might be community-based. And then there are practices, many of you have some co-located mental health providers, or you've got a really close referral agreement with a few mental health providers who see your patients. So be thinking about that framing. And I can't see everybody's faces, but I'm scanning. I'm having Renee scan for me now. Is Doug Bennett on the screen?
I am.
All right, Doug, I'm going to have you go first. I took your wonderful, so I just want to say that I reached out to Doug and also to a couple of other folks you'll hear about soon, just saying, would you be willing to talk about your model? And not asking people to do a formal presentation at all, but really framing questions that I gave to them about what's the longevity of the partnership and what you've been engaged in. What are the referral communication, documentation, billing pathways? How does the HP care manager interface with this resource? What do you think the greatest benefits are, not just to patients and families, but to your team and to you? Barriers encountered in doing this work and how they were overcome, and then advice for practices looking to enhance their model. And Doug, you don't have to hit on all of those things, but you sent me some great stuff that I did pop into slides, your points. And so if I throw those up there, you can talk to the slides, you can ignore whatever you want to go with this. So it's very fluid, and I'm going to turn it over to you.
All right. So we've been using a hired psychologist probably for about 5 to 6 years, really more actively in the past 3 years, right before COVID, who is full-time employed on salary. And we thought that was the easiest way and best way of work collaboratively and having some control about referral patterns. I mean, we had a hard time figuring out how we're going to do it. Is she going to see everybody all the time? And do we just do it temporarily as well? I mean, as of now, she's pretty well booked. I mean, if we have her intakes, it might be 4 to 6 weeks to have an initial intake with her if we needed to, but we always have emergency slots available for patients as well. So, I mean, I guess I'm talking about, so spot-wise, if you looked at it in number 2, I mean, we have some same-day behavioral health. You know, if we, for example, I had a patient whose grandmother died the day before and had issues of how do they deal with that, and I had them come in the next day. If we have a patient who calls up with some cutting or suicidal thoughts, we might even squeeze them in the same day and get them in and get them set up. But typically we try to do a intake and try to get them in within 3 to 4 weeks. And then we have her seeing patients like on a short term. We might do 5 visits might be over several weeks to a month or 2 to try to find out what's going on, find out what their best needs are. And then we might refer out at that point to the community. It'll give us time to get them in somewhere as well. So she's made phone calls to practices throughout to find out who's available and who's not available as well. But you can see, I mean, looking back to number 1, I mean, this is over the past 12 months. And, you know, pretty busy. I mean, she does about 10 slots per day. And usually we're filled. Over the past year, definitely at least breaking even. I mean, so I guess our goal is for mental health for our patients. Yeah, it'd be great if we can make a profit, but if we can break even, then that's great. And we are breaking even, except for now, since it's going, sick visits are down again recently, but it changes, comes and goes. But we find out that it really is a true collaborative model with her, having her in the office. She's in the pod with us, you know, so I'm seeing a patient and something comes up during the well visit. I might even knock on her door and she'll come in and we do a warm handoff. And so she'll meet them right then, and then they'll be comfortable in seeing her the next day or 2. Collaboratively as well, as if we have questions throughout the day, she's always there to consult with us. And I guess what also is very helpful is that helping us make care plans. So, you know, yesterday we just had our our monthly doctor's meeting, and we developed an ADHD 3-visit algorithm and collaborative care of how we're going to see these patients, evaluate them, doing PHQ-9s, doing SCARE to find out is it really anxiety or ADHD coming up, getting things going and following up with her and us throughout the way. She might help us make decisions about medications as well. So I'm pretty happy how our collaborative is working in our office. As far as AHP involvement, she does meet with Lynn. We're trying to have her meet once or twice a month to work with social work, because Lynn will reach out to those families who might miss visits with our behavioral provider. Lynn will get other social work and other people involved as well. So we definitely use AHP and our care manager along as well. And the barriers are just like anytime, sometimes patients don't show up, but then we can follow up and find out why they didn't show up as well. Visit wise, so we did have her get credentialed with all insurance plans. It did take a little while, so sometimes we did some creative billing so we can get covered. We might have expanded our 99213s and made it a 99215 and said it was prolonged because we spent 60 minutes with them combined, and she was a kind of like a nurse and provider, so we could have expanded until we got total coverage, but she's covered by all plans now. And we split up the visits different ways. She makes lots of phone calls to schools as well, talking to the psychologists in schools, talking to the teachers. And the way we bill for that is we keep track of the time she's on the phone. And so you can bill with team meetings with increments of time, and then bill total once all the time is together. So we can have that documentation for the patients. Again, it doesn't really cover all the costs, but it'll help with a lot of the phone calls she makes as well. Many times she meets with parents alone, so we can bill family without patients, without the patient there as well. So it's a lot of creativity that we've been able to do, having her in the office, and I feel it works pretty well. Are there any questions about how we are doing things? And I talk very fast, so I glance over things.
I just wanted to compliment you first, because I think it's just it's a really exciting model, and it's exciting to listen to. Was that Katie Edwards with her hand up? I think. Yeah, go for it, Katie.
I was just curious because I know we looked at trying to set something up similarly, but it was before COVID, and maybe I misread or some of the guidelines, but there was something in the fine print that said if you were going to have a psychologist in-house, that you had to have some kind of a supervisory, like psychiatrist or someone that would like sort of oversee their work. And it didn't seem that any of our credentials would cover that, at least from what we were reading. Maybe I misread it, but I guess that's my question. Did I misread it, or do they have to have like so many charts reviewed, or how are they?
I didn't come across any of that, and I haven't heard about any of that. I mean, I pointing out, I'm gonna have to review and see if there's some additional things. She did a lot of review as well. I mean, so her training was in collaborative care as well. So she came knowing what we needed and what didn't need. So it didn't come across in our negotiations and discussions where that was needed, that oversight was needed with a psychologist. I mean, because if they're in private practice, they don't have oversight.
No, now that I think about it, it may have been more of a social worker. I wonder if I was looking more at social work credential. I wonder if that's the difference.
Full PhD psychologist in private practice. I mean, our one thing was whether we get in trouble for self-referral. So that's one reason why we got her under our own tax ID number. So really, she's part of the practice, so we're not getting in trouble with any federal laws of self-referral for that as well. So that seemed to make it around.
That's very cool.
Other questions or comments? So I'm going to move it on to Katie Edwards, because Katie was willing to talk about their practice model. Go ahead, Katie.
Sure. I was going to say I wasn't put together as but I do have a little Word document. I put a little bit of notes down, just kind of going towards those few questions you had raised earlier. So at Stony Brook Peds, our current model involves a very close collaboration with Noyes Mental Health, which is one of the county health departments that is located down, believe it or not, down the street from the Dansville School, and now actually has a new facility opening in Avon, or has been opened. And that relationship and collaboration has been going on for years. I want to say even well before I came to Stony Brook Pediatrics 14 years ago. But the relationship itself has sort of evolved over the years, especially after COVID and the loss of their main staffing psychiatrist. They sort of had a rebuild and a reboot, and they've been in sort of this holding pattern and rebuilding phase ever since. I had a ton of staff turnover between some of the mental health nurse practitioners, as well as the counselors. So there, and before that, we were trying to keep quarterly meetings to sort of have them, meet with us as groups so we could get familiar with faces and referral names, things like that. But I will say since COVID, it has sort of dropped to the wayside. After COVID, Glenn Hahn, one of the mental health nurse practitioners, took over, and he is trying to rebuild. And I want to say there's about 3 or 4 mental health nurse practitioners there now, and they are starting to get more counselors on board. And we have this dedicated time every Thursday with Holly Brown that AHP has given us, that we have invited him to, and he's been able to come a few times. So it's again trying to rebuild that connection and the ability to set that time aside to do some case review and collaboration. So the referral process, as far as our current referral structure, it is in accordance with the referral agreement that URMed and Noise Practices have. And it sort of ties into our PCMH NCQA accreditation, where we have an agreement that says between all the URMed practices, this is what you expect from us, this is what we expect from you. And it sort of maps out, the consult note within a timely period, warm handoffs and phone calls for anything special or ideal. But it is a little bit more formalized with a referral agreement process. Billing is sort of a separate pathway for us. And in a sense that there's really no sharing of billing scenarios there. As far as AHP's interface, that has been huge for Stony Brook Pediatrics. So as stated previously, Robin McGilligan and now Robin Shep, and then Holly Brown, we have every Thursday from the noon to 1 o'clock hour, a Zoom meeting where all staff are able to get on and present any mental health cases that seem to really be difficult or needing an extra level of care. And then Holly is there for us to bounce off medication questions or other management questions. So that's been a really protected integral time that we've used to invite, as I stated earlier, the noise mental health folks to kind of join in on. And then Holly's been a great benefit for those consultation services as far as sort of bridging in between. I think the biggest thing that a lot of our providers feel, and families will give as far as feedback, is they really want to see a child and adolescent psychiatrist. And the mental health nurse practitioners, it just seems that sort of there's such a huge need in general that the adult population seems to kind of fill up some of the slots quicker than the kiddos. And then, in some of these collaborative meetings, they'll say how multifactorial and difficult it is taking care of the kids. So I don't know if the comfort level is quite there. But what's been greatest benefits is that it really brings that comprehensive care all together, breaks down a lot of barriers between the transportation and insurance issues. And for the providers, feeling that support from the ever-growing uncomfortable situation of the escalating acuity with the mental health stuff. But for example, parents will say, I don't think, they're going to noise mental health and I don't think their counselor's helping them. And I'll say, why? Oh, because she doesn't seem to have any strategies or this or that. So then in these structured visits, I'll say, Johnny's mom came in and said that they didn't feel like they were really making a lot of progress. What do you think? And it would be interesting then getting the feedback from the counselor. Well, I think Johnny and I are actually doing really great. And that, maybe the mom is a part of, some of the other issues that play in. So I can see how hard it is for the counselors to deal with the child and adolescent. And then the other pieces are autistic kids or kids with disabilities. They really seem to not have a comfort level with being able to help those kiddos. They obviously need, you know, a little bit more specialized. So a lot of the times they'll say, we can't handle that, or can you refer them up to behavioral peds at Strong? Which again brings us back to some of the barriers for transportation and other things. Other barriers, so you know, things come up time, but I think time is the biggest thing for each end of that relationship to come together. Finding that uninterrupted, dedicated time that stays consistent. Because like I said, over the years, we've been able to really, like, I remember there was maybe one year where we had a couple of meetings in a row. And we thought, oh, this is great. We're really collaborating and feeling like we're on top of cases. And then something happens, staff turns over, or things get busy in the clinic, and your participation kind of seems to sort of wheedle down, as well as role changes. So as far as advice, I think it's huge that if you have the ability to make these connections, to really, I think for families, it really does make a difference. And that communication seems to be really key around these relationships. So trying to make that time, I put a little thing in here. Also, that dedicated Thursday time, I would be committing a sin if I did not mention that it's also beneficial for our providers. I feel that the Robins and Holly also counsel us. You know, how tough some of these cases can be and how frustrating it can be coming up against a system that seems hard to get access to, that they'll sometimes, you know, just hear us out. And that's been, I think, a really beneficial thing, which kind of also plays into that trauma-informed care program that we're participating in. I think that's been a huge help for us.
That was
But
really
any-
helpful, Katie. Thank you. So any questions for Katie or comments? You're all on camera, but you're quiet. That's okay. We let that go. So now what I'm going to do is just open it to you all. So thinking about what you're currently doing, is there anything you feel that's kind of innovative you'd like to talk about? Many of you do have, I think, sort of a business agreement, like a referral agreement with someone, or possibly even someone who's co-located or in the same building or right, you know, down the street. So I wonder if for people who have that type of model, if they want to talk about just a little bit about their experience or what they like about it or what they are wishing for. Again, we're all listening, like listening to attentively to try to be thinking with you. Oh, you are tough. I even like waited an extra, I counted extra 10 to not like break the silence, but you broke me. I couldn't hold out any longer. Joanne, you unmuted. Ha, I saw it.
Got me. Well, we don't have this agreement currently, so it's old, but when we first opened our practice, we had a psychologist that was co-located with us. So she had her own billing process and scheduling, but if we needed her, she would often pop in. The warm handoff was great to do. Like, so if I had somebody and she was able to get them in and she had the time to pop in and say hi and schedule that was really helpful. COVID sort of messed everything up and she had to go do telehealth and it just didn't work out anymore after that. But it was a great model. I love the idea of having someone on staff too, as well. She saw, you know, our patients like were definitely a priority for her, which was really helpful as we struggle to get people in now anywhere. And then she had her own patient panel too, that she had, you know, that other people referred to her, but it was great to have someone on site.
Thanks for that, Joanne. I'm looking at some of you on camera and I'm wondering about how, I don't want to put Kurt Kramer on totally on like on the spot, but I'm thinking about rural family medicine practice, how this is working for you in that space. Do you mind commenting on that?
There we go. Yeah, we have a referral agreement with a clinical associate group. And what's different for us is that we allow her one of our laptops. She does her notes right into MedEnd, and she has access to our information, and we have access to her information, which sometimes is not a big deal, but sometimes it is. And I think it especially gives her a lot more background into why that patient's coming to see her. She doesn't have to maybe dig it all out. There's a level of familiarity that's already there. We do a lot of warm handoffs, and our social worker's been very, very good about that. And I think the other thing that's good in having it in the doctor's office is that there's a level of comfort there from the patients. They're not going to a dedicated mental health facility. They're coming to the doctor's office, and I think they're already comfortable there, and that works really well.
Sharing that, your comment about being able to share in the record and being able to deliver some care in the office setting. I want to give a little shout out to the AHP social work care management team, because I think that that's one of the really great things. Even though there's not one dedicated care manager to a practice, that access to the electronic record and the relationship that develops over time. I think that I know from all of you that that's been really instrumental and helpful to your teams. Anybody else?
I just want to reiterate what Dr. Kramer is saying, that like today, so we have a co-located psychologist in the office, which is great because there's a lot of, we talk every day. And I would say about half his practice are my patients and half are his regular practice. But it just a funny in pediatrics. So today my nurse went to the waiting room, and in the waiting room is the dad of one of my adolescents that she's trying to pull back into my visit. And one of the doctor's patients, who's also my patient, a little 5 or 6 year old, assumed that she was the one getting called back, because that's just what happens, because she is that, she's our patient. And so when the nurse comes to the door, she comes in, and it was just kind of funny that comfort level. And I do feel it breaks down barriers for those families that don't, have this bias about going to a therapist or psychologist, because it's just, well, okay, we're just coming to your office, and that's okay. And they can meet him. And it's been great. And again, same thing, just to be able to say, hey, can you get this patient in? And here I can give you all this background in about 2 seconds, and there's no phone tag, and then follow up. So.
That follow-up and that communication is so important. I know you've all talked about this and experienced it and have for a long, long time, but there are some people who are wonderful about giving a call after they see a patient or sending a little note, but the vast majority, you're really working in silos, and then you're seeing the child back and having no idea what's happening on the other side. So anything to be able to, bridge that, I think, is so valuable. So anyone else want to volunteer? Other thoughts you have or things that you wish? We're not necessarily in the ability to deliver on all wishes. I will be honest about that, making people on the screen nervous, but it's helpful to know. It's helpful to hear.
I'll volunteer as a rural pediatrician, ALJ.
Hey, Gail.
35 years, but I will admit to retiring in 4 months. So, 40 years of care for children. So, but I will admit, mental health through the years is like setting people next to a dinner party. I know certain therapists who are good for adolescent girls with anxiety and kids that are, so I actually have a list that, like, okay, let me see if I can fit this one with that one. So it's like my own Psychology Today referral network, because it has been difficult. And like Katie Edwards, Noise Mental Health has struggled. They had this fire sale a few years ago and no one was there, and everyone got sent back to us, and that was chaotic. And they're better communicating, but everyone struggled. So, COVID aged me in dog years, and I'm sure it's aged mental health therapists also. But you're working with a community of people, and it helps to have feedback and back and forth. We don't have anyone specific at Tri-County, although our CEO is a psychologist, but being the one pediatrician in a family medicine group, it's a lot of adult concerns, and they're as overwhelmed as children. Trust me, my colleagues will tell you, we think kids are overwhelmed. The adults are, as you can tell by what's going on, are pretty overwhelmed. So Noise Mental Health struggles by having to treat all. We're trying to help them at the youngest age, but we do have a number of private providers that can see different kids for different issues. But I'm happy to be sort of on the win song of all of this a bit. Still struggling. Yeah.
Gail, it is always just a pleasure to listen to you. I always learn, and I just have to give a pause from it. If you all heard that, I saw like a congratulations in the chat, but I'm sure your patients and your families will be crushed that you are retiring, and at the same time wish you so much, so well. And
it's a painful heart song. Yes, it is. It's a painful thought. Yes. Yeah. But thank you.
Thank you for sharing that with us.
You're welcome.
So we have just a few more minutes on this part of the agenda. So I'm wondering again, if anyone else has anything else they'd like to add from the practices. And if not, I would invite, if anybody from the AHP team would like to make a comment. I have to tell you all that unfortunately, both Holly Brown and Robin McGillicuddy could not join today, Holly is teaching a class that was the last one. And so she was actually doing the teaching, so she could not be here with us, unfortunately. But George Nasra is here, and then Elisa Stetzer and a number of our care managers are here. So if any of them have any comments or anything they'd like to reflect on before we move on to the next agenda item, that'd be great.
I want to thank everyone for participating in this conversation. I know it's not an easy one to step into when we feel as though there really isn't a lot to adjust. So thank you for making room for this difficult conversation and even just the tiniest little bit of a crack to consider the ways we can adjust. I also want to thank our care managers on the call today. I know we have a few of them. They do an incredible job in supporting all of you in whatever model you have invested in. And I love that we have that level of flexibility and partnership and the responsiveness to not just the patients and the families that you all care for in tandem, but the differences in each of your patients and families' needs and the models that you've chosen to put that forward. It's so incredibly brave to me what you do. I really, really admire it. And anything that I can be doing to support our care managers to continue to support all of you and the models that you're putting forward, please do not hesitate to be in touch and let us know if you did experience a little bit of a crack in letting a little bit of light through today. We'd like to hear about that. We'd like to understand what that was for you, whether it's now or in 6 months. That's really helpful for us to understand and to understand more of what was shown by the light. Thanks, everyone.
Thank you, Lisa. And I would just add to that. So as you're kind of thinking about this or later thinking about the session, don't hesitate to shoot an email back to me, a copy of Lisa and Holly. If you heard something in here that really piqued your interest, or your practice would like to be thinking about other things. And I think the one commitment that our team definitely one of probably several commitments, but this whole notion about the sustainability and the billing for this is really, really important. And Doug, I love what you said, like you're not looking to make money of this, but you have to be able to continue it and sustain it. And so there are some new billing codes that are coming, one in particular coming through the state Medicaid budget and through the guidance. This year we'll have more information to share on it. People are just starting to sort out where and how it can be used, but it's going to be really valuable in the, particularly, I would think, in the younger child space, because it essentially allows, when there's some type of intervention, evaluation and intervention done, a provider can bill without a diagnosis code. So if you think about all of that dyadic care, infant mental health, some of the stuff that we do with families with young children, it should really help in that space. And George is just putting a really nice thing in the chat. Please remember that the entire BH integration team can be reached by email, and that is in the chat there. Okay, so I'm going to shift gears here, but before I do, I want to just orient people who came in a little bit later to the Zoom room, and you're probably looking at the introductions from other people and thinking they've had like a seizure or something happened, like why they're putting in these songs. So should you like to reintroduce yourself again in the chat? The prompt was, what would be a sort of a pick-me-up song, your favorite pick-me-up song? You can put it in there. We're generating a playlist. Won't happen tonight, but we're generating a playlist. Go ahead and put that in the chat. And then I think I noticed when I was going through the screen, we have someone who is iPhone only. And I'm hoping we do keep attendance through this, so you won't get credit unless iPhone you unmute. Or if you can just put in the chat who you are, that would be really helpful to us. That would be great. Okay, I'm going to turn it over to Bob Adams. Bob is going to talk to us about the stimulant medication shortage and a couple of other pharmacy issues. Thanks, Bob.
Great. Can you guys hear me okay?
Yep.
I'm going to attempt to share my screen as well. Can you guys see it all right?
Yep.
Looks good, Bob.
All right. So yeah, thank you. And I'm going to also try to pinch hit for Holly a little bit and do my best to channel her. But I want to take a few minutes to kind of talk about the ADHD medication shortages that we're all feeling. I wish I had some good news to say and it could bring some magic to fix this situation, but unfortunately, the burden caused by the amphetamine salts, now the methylphenidate shortages, will likely continue through 2023. The main causes, it's a bunch of for the shortage of the usual suspects. More and more generic manufacturers are consolidating. In some cases, they've even stopped making the medication. 3 that have left in the last year, Mylan, Adelon, and Patriot, all made medications that were in the stimulant space. And then a new actor, though, has kind of come onto the scene as far as what's contributing to the shortage. It has grown out of the COVID-19 public health emergency controlled substance policy that went into effect on March of 2020. We all remember that. This allowed new telemedicine platforms to grow in the controlled substance space. And this has led to a surge in adult ADHD diagnosis via telemedicine. Since 2019, Adderall prescriptions have increased 19%. And this is also where kind of an indirect problem has come up. The DEA sets the aggregate production quota for raw medication, for raw materials. And you don't necessarily see how that can play into the situation, but the DEA is concerned about the growth of ADHD stimulant medications and feels that there are illegitimate uses happening in the marketplace. Therefore, instead of where they generally trend to increase the amount of raw material that's available for manufacturers to use, they've decided for 2023 to hold constant. So they're not increasing any more raw material that's available for the manufacturers to use and produce these stimulant medications. And then they feel that the amount of material that's out there or that they released in 2022 is enough for the legitimate needs in 2023. And this is, in my mind, could play a lot of potential for problems further along in the year as we get closer to the end of the year, because they're not allowing for more raw materials to be out there. So, what can we do to try to help with this? A couple of things that we've kind of put together, some materials. I really want to give a shout out to Dr. Bandari from Legacy Pediatrics. She turned us on to this excellent graphic that the Cohen's Children's Medical Center out of Norwell Health created. And just to give you a little bit better view of it. So it gives you a pretty good rundown of the products available in the market with some comparative dosing among the different types of stimulants in the market. But I would caution you, it's not like a column type arrangement where we can just, oh, there's no Concerta left. Let me just drop down to Focalin and we'll go with that and try that and could do a quick, dose-to-dose conversion. Because remember, these are different molecules, and so they are going to behave a little bit differently in your patients. And this is something that you generally titrate the patient up to. So you want to, have some thought and consideration how you may move from medication lanes. Now, we are also, let me just move my notes. We will continue, and we also continue to put out information in our pharmacy pearls. This is a place where we can, as we meet with a group of community pharmacists and wholesalers, to kind of look at what's available in the marketplace. And we do that every 2 weeks to see if there's any change. What are we seeing in trends? And that's where we get some of this information about what's going on with the DEA, what's happening in the broader context. And when we get that information, we'll definitely promote it within our pharmacy pearls. So we have a couple out there already on methylphenidate and the amphetamine salt shortages. And so I'd encourage you to take a look at those. And we're always looking for feedback in that space too. We'll also put together, we'll have some links for you if we can, where did I come up with that stuff about the DEA? Where's that coming from? There's some information here for those of you that want to dig a little deeper and see what's happening in that space. Now, this wasn't on the agenda, but I did kind of reach out to LJ and see if this might be a good opportunity to talk a little bit about what's going on with New York State and their Medicaid shift from a managed care to a pharmacy benefit fee for service to NYRX. So as if the shortages weren't a problem enough for a drain on our resources, on April 1st, 2023, New York State moved its Medicaid pharmacy benefit to fee-for-service through a plan called NYRX. So what we've seen so far in the first 2 weeks of the change is that providers are likely going to see an increase in refill requests and maybe prior auths and alternate agent recommendations coming from pharmacy. We're finding inconsistencies in the plan, inconsistency with the state plan. They're also putting out drug-dependent clinical criteria. And this is, you kind of assume you write a prescription, it's good for a year, and it's good for X number of refills. But we're finding that they are putting out things that are drug-dependent, and they're putting in extra criteria. An easy example that we've stumbled upon it and found is, lidocaine patches. They're only allowing for 30 patches for a month and only 2 refills. Why did they do that? We're not sure. We're still trying to get to the bottom of that, but it's just sort of popping up. We're not seeing the consistency that you would expect to see when you write a prescription that should last for X number of refills. They're also allowing transition refills for the conversion months, kind of April, May, and June. And what happens during this, they're allowing whatever medication the patient was on, they're allowing you to continue that refill. So you can see that these refills are going to trigger a potential for prior auth if it's not their preferred agent, or an alternative agent to be recommended by the pharmacies. The problem is it all is going to be depend on when the patient is going to make the do the refill. So in the first 2 weeks, just talking about our own URMC affiliate pharmacies like Highland South Wedge and the outpatient pharmacy at Strong, they saw over 1,500 scripts come through with that transition fill medication flag. And so that means that 1,500 medications in the next fill in May are going to be require either a switch to an alternative agent or a prior auth. The team at Highland and out, within our org, within our structure, the URMC affiliates, is working hard to try to get ahead and get information out to the providers as to, hey, this medication is not covered. It won't be covered next month. These are some alternative agents. But we don't know how that's going to affect, the chain. So like what Wegmans, Rite Aid, CVS, how are they going to handle this information? How are they going to be getting this information back to you? We are seeing, though, that the prior auths that have been put in place before 4/1, that it looks like the state is honoring those for whatever the duration of that prior auth was set up for with the previous carrier. So what are we concerned about? Well, at the office practice level, we're more concerned about the administrative burden that having more PAs in the coming refill requests will make. There also appears to be kind of a lack of awareness around the change within Medicaid that took place on April 1st. We're still seeing prior auths that are being sent to Excelis because Excelis is listed as the medical benefit for the patient. PAs having done under the, and then PAs also have to be done under the provider that's registered with Medicaid. We know that URMC pharmacies are trying to send out communication to providers when patients have transition fills, but we don't know what the chains are doing or what their plan is going to be and what that will look like when it comes to you. We have heard reports of some independents. They still have not been paid by New York State independent pharmacies. This could present cash flow issues for them. Several of the prescriptions that are being processed now and being analyzed are upside down. They're not being reimbursed for the cost of the medication. If you're a 340B eligible entity, you're being paid your acquisition cost plus a $10.18 dispensing fee for the product. So it's a very small margin there. So we know that there's a lot of number crunching happening across, institutions and pharmacies right now to find out how is this going to work? How are we going to make this sustainable? So that's definitely concerns that we have right now with, what's happening with New York State and NYRX. Got some links for you if you're interested to find out more information about, the NYRX program. We put out a Pearl as well just prior to April 1st. And then, there's a new NYRX's pharmacy medication managed PBM is Magellan. They do have a site where you can go and reach out to contact them. I have contacted them. I have not heard anything back. So I'll contact them. That was prior to even April 1st to get a handle on, what are the things that we can expect. And we'll continue to try to reach out and make some contact with them. I'm sure there's some questions.
Yeah, I was just gonna say, opening the floor for questions.
I don't really have a question other than to say the ADD shortage is extremely frustrating for the patients in particular, for the office staff, for everybody. And I don't know that there's a lot of advocacy that could be done. I mean, one thing is that this isn't the biggest deal, but like, for example, if there's no Adderall, and then the insurance company still wants a prior for Vyvanse. Again, that's not the most frequent problem. Most frequent problem is they just don't have it. The other thing is that, for example, Wegmans pharmacies, a whole chain of pharmacies, like one might not have it, but the next one might. They do have ways of finding out which pharmacy has it, but mostly they're going to refuse to do it. And mostly they're telling the patients or us, you call around and figure it out. But I've had patients who call, Wegmans shipping, and they actually did know which pharmacy had this or that. So I don't know from an HCP perspective if there's any kind of advocacy that can be done with the pharmacies to say, don't yell at the patients and tell them they're drug seekers because they called to find out, do you have this medicine? Because they know there's shortages, stop harassing the office and just dumping it back at us. They frequently put it back electronically to say, we don't have this, pick something else, but they don't tell us we have this dose, not this dose, we have this brand, not this. So I think some advocacy with the pharmacies to say, you're not helping the system, you're only upsetting the patients, the providers, and everybody.
Very well said, Carolyn. I saw Liz unmuted or hand raised, or maybe it was Katie. I'm sorry. Was it Katie? Not Liz?
Yeah, I was just wondering also with the antibiotics, do we have any idea, is that going to last through 2023? I know that's gotten better, but you still get we don't have that.
It got better and then it got worse again. Now it's worse.
Yeah. Yeah.
Bob, do you have thoughts on that?
Yeah, no, it has gotten better, and I think it will get better. I think, part of, the move to just-in-time manufacturing that just everyone uses, no matter if it's car parts or medication, when you had such a decrease in the disease burden over the last few years, everyone ramped down the production. And so now they're having to ramp it back up and get those things out of there. We did talk about that just the other day, and within the wholesaler, we are seeing that the antibiotics are available. So it seems like most pharmacies should start to have access to the antibiotics. That shouldn't be an issue. It could still be pockets of places that have it, but I would think that the chains they shouldn't be skirting you around like they were many months ago. We're seeing that, Cardinal as a wholesaler has it available to order. So I think that shouldn't be quite the issue that it was.
Thanks, Bob. And Carolyn, I'm really hearing your question about advocacy. We've been talking about, Bob and I talk about this like almost every day, how we can advocate more. It's tricky because you're talking about commercial pharmacies and then you're talking about some of the centralized pharmacies. It's not all the same, but it's worth a try. I mean, we managed to do a lot of things that we thought we couldn't do during the pandemic because, it was just like you had to. And so it's worth leveraging those kind of relationships again to try. So, and I wonder, since it's bigger than an AHP issue, it's a community-wide issue. If this can be something that we pull together with, with GRIPA as well as AHP and Monroe County Medical Society and sort of like all put pressure together, which is better than it coming just from one, or maybe not even pressure, but at least advocacy and partnership together with them. So thank you for bringing that forward. Other comments? I've seen two things in the chat, but I wasn't. Oh, okay.
I had a question.
Yes.
So I heard a rumor that all prescriptions for Medicaid patients are going to need their Medicaid number written on it in order for it to be filled by a pharmacy under this program. And that isn't something right now that our medical record can do. And so that's a lot of extra copying and pasting. So I was wondering if that was true. And the other thing I was just curious about was whether anyone else was using the MedCalc app that like changes, Adderall to Vyvanse or other things like that, and how well they're finding that works for them. I'm usually afraid to go straight to whatever is recommended because it can be so different, from one med to the next, how it absorbs for that kid and whatever. The last time I remember somebody giving a lecture on it, the curves look like a spaghetti monster, like this is the way it's supposed to go, but actually it's like that, and so it's really hard. And I think it's really hard for parents to understand that too. They just want can you just give me the other antibiotic? And it's like, these meds aren't like that, and you can't just you can try, but you can be way over and way under, and then people get upset about that or concerned about side effects, and then they won't go back to that med. So you have to be really careful, or else people, so I think that's the other thing that's just been really challenging and is taking a great deal of time, because every single one of those is a phone call or a visit. It can't just be I'll just, unless it's like 2 5s instead of a 10, that's easy, right? Other than finding out who has it and how many and that kind of thing. I'm curious what other people are doing it also about the 90-day versus 30-day thing. People are understandably asking for 90-day supplies because if it's there, they want to solidify that. On the other hand, so there's no sort of public health concept of what's okay right now. So we're granting people's requests if they can get it, but I was curious what others were doing.
Well, I can answer your first question about the Medicaid. That is definitely a rumor. We haven't heard that. My guess is some of that could come out depending on what pharmacy they were using, what technology they have. Most of the pharmacies can access and look up the patient's SIN number, get that information. You don't need to send it out there, but maybe per chance there was a independent that didn't have access or hadn't figured out how to do that yet. We're not seeing that you have to add the patient's Medicaid number to all the prescriptions. We haven't. That's definitely a rumor. And I think that's what we kind of liked about that chart. It doesn't tell you exactly like a calculator, go from this to that, but it gives you kind of an indication of like sort of like the lanes, like so you can kind of back it down a little bit, start a little bit lower at a lower dose at a different medication type and titrate it up, because you're really kind of titrating to the effect. And you're right, there's a lot of technology involved in these medications, how the medication is delayed release, or it's biphasic, or all these different things that kind of, it's going to be unique for the patient and their experience. So I wouldn't recommend you would just go, automatically switch from using a calculator.
I have a couple of comments. We have the same problem where sometimes pharmacies are listing off other alternatives, and by the time we land on something that's really working well for a patient, the last thing we want to do is switch it around. Not to mention that in the EMR, like I try to keep what they were originally on so that I can go back to that someday. And then sometimes we have like a couple other things listed now in EMR because that's what we've had to resort to. So whenever possible, we are really asking the families, we just don't have the staffing, but we're asking the families to call around. And I think they're starting to get it, that that's just going to be part of the equation. But just listening to what Robert said, I don't understand how this will ever work. I mean, if basically the problem has to do with much, much more of the medication that's being produced going to adults because of this telehealth situation, then, I mean, how do we ever ensure that the kids who legitimately need it are going to get it if we're not increasing the supply? Like, this equation can never work.
Sarah, that's the conversation Bob and I were having like this when he was explaining. I was like, what is this due to? And I'd read an article about the overprescribing. I mean, it's worse than, this is a safe space, right? We're being recorded. No, it's even worse. If you really look at this, some of these, not all of the telehealth companies that are doing behavioral health, but there are some in a for-profit world who are getting kickbacks for prescribing medications, right? So that has been stopped reportedly. But if you just think about the world we live in, how do you continue to take good care and have the right medications available and the right treatments available for people who need them, right? And for kids who need them, who are always not at the front of the line in most things in healthcare. So I think from an advocacy standpoint, I don't know how we do this, but I think it's a much bigger, higher level advocacy thing. So Carolyn, when you brought this up, I wanted to come back around. I think the AAP, the APA, all of these organizations need to get out there and just hammer home the point that this is going to be the next, and it already is part of a crisis, but there's not an easy solution out. It's just going to get worse from what we're hearing. So we will continue to work locally, but I think elevating it, those of you who are members of the American Academy of Pediatrics or the American Academy of Family Practice, I think like starting to raise the white flag or whatever, and then calling for help from the organizations would be important. So Bob, you had a tricky topic there. I'm grateful for you for jumping in.
Yeah, I hope all the bad news you guys will still invite me back in the future.
Yeah, well, we're gonna think about now. You're part of the solution. I do want to mention one other thing, and we will make sure y'all get follow-up on this, but this is important for pediatrics. One of the other things, thank goodness for Katie Whiteman, who's our lactation care manager within AHP, who's doing such a lovely job down in the Dansville and Noise area with enhancing breastfeeding rates, but she had done a big push several years ago to make sure that families who were breastfeeding would be able to be given appropriate pumps with enough suction to actually continue milk supply so people could go back to work. And that's not the only part of her model that's worked, but that was a really critical and successful thing. Well, surprise, under this new program, the pumps that were initially being chosen are substandard. They're 9-volt, and that's not enough to sustain lactation. So Katie recognized it immediately, has started this whole advocacy thing, but we're not sure how far this has gone across New York State. I mean, this is locally. She is working with teams to make sure that they will be having, that anyone who's on Medicaid is not going to now have another hit against them to not have an equitable pump. But it's the kind of thing that we would ask of you all, if you're seeing something like this, not just the shortages, but these like unintended disparities that, or, unanticipated inequities or disparities that are coming up, please let us know. And we'll keep you posted on that, but we hopefully locally, this one will be resolved. Dental care, amen to that. Okay. That is huge. We'll work on that one, but not in this meeting, Katie. All right, folks, thank you for that conversation. We're going to switch gears again, and the rest of the meeting is really just kind of a few updates for you all and a couple questions. I'm just going to introduce to you the topic of, I have to be able to share my screen and multitask at the same time. I'm sorry, hold on one second. Oh, we went right back to the beginning. Are you seeing my screen? Oh, somebody tell me.
Yes.
Okay, here we go. There we go. The HPV Start by 9 campaign. Anybody who joined our our AHP, wow, too many acronyms. Maybe that'll be the next little thing in the chat. You can put your favorite acronyms in the chat next time. If you were on our AHP Wednesday call, I made mention of this, but the American Cancer Society is now launching an HPV Start by 9 campaign. And I just wanted to give you the highlights of it, and then you will be seeing more information coming out, but just wanted you to be aware. Again, it's being led by the American Cancer Society. Why? A couple of reasons. A, our rates are not what they should be for HPV vaccination completion. So this is not even looking at the HEDIS metric. I'm not even talking about that, by having kids receive 2 doses by 13. That's not even what I'm talking about. The number of children and adolescents who do not complete the series is profound. And so they've been really looking at the evidence and looking at ways to improve that. And the evidence does show that an earlier start does lead to better series completion. It allows for a different dialogue with the family, a dialogue that's focused around this is cancer prevention, as you're talking with the 9-year-old, as opposed to you're talking with a family with an 11, 12, or 13-year-old, where the conversation all goes to sex. And it makes the whole thing very uncomfortable to be able to move forward with. Also, it leads to a strong immune response. We know this, right? That's why we have the 2-dose series rather than the 3-dose series when you give the vaccine at a younger age. So I wanted to highlight to all of you, there is no change to the HEDIS definition. So like to the metric that we're performing to, this is nothing about metrics. You're not now expected to have everybody have their vaccine by age 11, not at all. But the endorsements are growing for this, and there's a huge long list. National organizations like the AAP, the American Cancer Society, the National HPV Roundtable, Local League, also Children's Hospital, Rochester Regional Hospital. There's a number of organizations that are joining on, including Accountable Health Partners. So what we wanted to let you know is that their launch, kind of their official launch for this, is anticipated to happen sometime. It's probably not going to be until June, but it could potentially happen in May. And you'll know when that launch sort of starts. We'll be sending out an endorsement letter that gives information that you can share with your practice teams. And there's a commitment we're making to y'all. We're looking at how we worked with you when we first started looking at the HPV vaccine rates with our population, and when we shifted over to adolescent combo 2. And we did a provider sheet for you. Probably remember it was the same day, same way information. And it was a 2-page document that had some FAQs on it, some basic information, and then also had some nice references. So we're going to utilize the exact same format, but we're going to re-up it for this. So you'll see that change coming. We'll be sending that to you all and posting it on our website. And the other thing that we recognize, I think the pandemic taught us this a lot when things were changing quickly, to be able to have a 1-page infographic that was readily understandable for families and helpful for practice teams and nurses and providers. There is not one that we're aware of yet, although we're working with the American Cancer Society to see what they have and see what maybe the AAP is going to put out. But if not, we're going to develop something for you. We'll plan to have these translated into Spanish, but if there's other languages that people need, please let us know. But I think this is a commitment we want to make to you all with these initiatives, that it's not just giving you the information, but hopefully giving you some tools that that you can put on your website or that you can share with your families as well. We've also talked about planning for an education session, not only for you all as practice providers, but for your nurses. So thinking about that so that everybody kind of is on the same page with this at the same time. And so that leads me to my one question, which is what else would be helpful for your teams? What else would you need in this space from us that we may not have thought about?
I would really love some very basic statistics about, you know, how many people are getting this, that, and the other thing, from, you know, in terms of the different types of cancers and what ages, that kind of thing. The one that makes people's eyes pop out that I heard a while ago was that more people are being diagnosed with head and neck cancer related to HPV than to smoking. And that one, like, that gets people's attention a lot of the time. So anything else that's like that. I think the other thing that's been suggested, but I've not seen it strongly in writing anywhere, is that you don't have to have like regular old sex in order to get HPV, if you know what I mean. And so that there's a lot of less contact than that, that is, you know, that is still, that's different than hepatitis or HIV or some of those other things. And I think that that's the other piece that parents are not picking up on, but there needs to be some sort of clarity on, like, what do we believe the true, what kinds of transmission is really happening with HPV, and what's the standard right now in terms of what we know.
That's great feedback, Liz. Having just looked at some of this because of our signing on the endorsement to this, you know, the quote is that 85% of people will be infected by HPV, 85% in their lifetime. So, and I think somewhere around 2,800 people in New York State are being diagnosed each year with cancers related to HPV. Now I'm talking like I'm the expert, and I'm realizing I think Cindy Rand's on this call. So I'm going to just ask Cindy if she has anything else that she would like to add. Is she still here? Oh, there you are. Good.
Yep. I was just going to say that I just gave an epi talk to an epi cancer class. So I have a very complete slide set on this, but I can find some like specific ones that I think would be the most helpful to just look at the incidence of different kinds of cancer nationally. And I think the New York State rates really help. We also have a map of New York State vaccination rates. I don't know if people are interested in that. And in speaking about like not intercourse, but touching being a way that HPV is transmissible, I think is important, but when you're talking about it at 9, you're not going to mention.
Thank you. Thank you, Cindy, for that. Okay. Any other questions on that? Shifting gears once again. So Kevin, do you want to share your slides, or do you want me to share your slides?
Yeah, I'll share my screen.
Awesome.
Sparky Round Pond reporting for duty, LJ. For those of you who remember our icebreaker from one of our last in-person committee meetings. Are we on the
Can I just tell people why we like, I don't want people to think we assigned that to you. That icebreaker, for those who may not remember or may not have been present, what Renee, help me out here. It was your
childhood pet name.
Oh, there you go.
And street you grew up on.
There you go. That's what it was. So you can all think about what your fancy name would be, but his won the day, because when he said Sparky Round Pound on his first day of work, he has forever been that for us, to us at AHP.
And I blush every time. Thanks. I'm here to share 4 slides with you today. We're going to be talking Bright Futures guidelines, kind of what is recommended by the AAP, and then the comprehensive development screening survey results, which went out in the fall of 2022, and kind of just gets you an idea of what screening tools are being used in the network. And then Mendon Pediatrics agreed to pilot a comprehensive development screening. So we're going to just go over that briefly, and then new AHP resources now available. diving in about Bright Futures guidelines. So what is recommended? Ages 9, 18, and 30 months for screening for global development delay, and ages 18 and 24 months for autism spectrum disorder screening. Then you can move on to this New York State Medicaid coverage, which shows the procedure code and diagnosis code. I'll have LJ kind of elaborate on that a little bit, but below that is the screening tools kind of validated, and examples of them are the ages and stages questionnaire, the ASQ3, the parents evaluation of developmental status, the PEDS for PEDS, survey of well-being of young children with SWIC milestones, and parents observations of social interactions, the POSI, which is the autism screener. And then the MCHAT, the modified checklist for autism and toddlers. LJ, did you have anything to add about the New York State Medicaid coverage, or have we learned anything?
I think the main thing in this is just to remind people that each of these, if you're when you're screening, as recommended at 9, 18 months and 30 months, those should be reimbursed once in that calendar year. You should be able to get reimbursement for that screen when you're using a validated developmental screening tool, like, for example, the ages and stages, or if you're using the SWIC or the PEDS. And then again, there is also reimbursement for the MCHAT being used at 18 and 24 months. And I say just the MCHAT because I think that's what the majority of you all are using based on what we've learned and what we've seen in the community. So, but just wanted to be there was a time where you couldn't get reimbursed for both. You were getting reimbursed maybe for the MCHAT, maybe for the other things were going out to people's copays. None of that is supposed to happen. Those are supposed to be covered. If they're not, please raise a fuss and let us know, and we'll try to back you up on that. Go ahead, Kevin.
Thanks, LJ. Any questions there? Move on to the CDS survey results. So getting oriented here, like I said earlier, this survey went out in the fall of 2022, so things may have changed. We had a pretty good response rate, but getting oriented to these tables on the left here, this specific tool for developmental screening, and then you can see the percentage being used in the AHP pediatric network to that second column. And then the table on the right is the social and emotional tools implemented so far. And I just wanted to note that 38% skipped this question. So some people may not be using that. I just wanted to point that out. Any other insights you have, LJ, about this?
I think I'm thinking on the left about the types of tools that people are using. We tried to just simplify this by putting those percentages in, but not everyone is using a tool for all of the recommended visits. So I think some of you you're really following the Bright Futures guidelines, but I think it's been tricky for folks. And for a long time, a lot of people have done surveillance, really, or sort of the assessment, like you walk in the room and you ask a few questions that are the things that a child is supposed to be achieving at that point, and you're sort of done. But in this state where we're at now, I think recognizing how much isolation and increased delays we're seeing, also knowing how important it is to be able to identify and recognize some of these delays as early as possible in order to get appropriate resources in place that can really make a difference in that amazing developing brain of children. We really want, our goal is to help you all, help our practices in our community follow the Bright Futures guidelines with one of these tools, but thinking from the AHP end, how do we make it better for you? So going back to the earlier conversation about sort of that integration model, and you talk about screening, how do you get the screens in families' hands before they come to you? So you have the results in your electronic record as you're seeing them. And then how do you do almost a closed loop navigation around referrals to make sure that once you've referred a child, they actually are getting in for services? We know you all filled this out in the survey. We all talk about this extensively. The delay in getting children in for either assessment and diagnosis for autism, the delay for getting children into early intervention is huge, but there is progress that is being made. It's slow, but there is progress that's coming in those spaces. And we're trying to look at alternative ways to enhance the availability for autism diagnosis, assessment and diagnosis. That's being worked on right now at the Children's Hospital. So that's all I have, Kevin.
Thanks so much, LJ. So we'll move on to the pilot where we're working with Dr. Lessig's team at Mendon Pediatrics. Thanks again. So we just really wanted to optimize the screening workflow, kind of what LJ was just elaborating on. And we really hope to scale this to the network eventually. So we've been working hard with, Dr. Lessig's team, and I just want to shout out Kate, her nurse manager, who's really been spearheading this effort as far as the MedEnt implementation. We started with the pre-visit planning, and this was one of our first successes in this pilot, where we switched from sending out to parents from 1 week out to 2 days out, and the 2 day out really. The compliance went way up, and there was no more chasing, and the workflow was much easier for Kate and the team there. So that was a huge success. And then moving on to the SWIC integration, we first met with the GCA, the Golisano Children's Hospital team, for advisement on the SWIC workflow, and we really learned a lot. And we took those recommendations, and we were really happy that we met with the GCH team, and LJ made that connection. But once we started with the SWIC integration, we kind of started implementing that. Dr. Lessig had a few screenings last week or this week, where we actually decided to hide the autism screener, the POSI, just to make the screening more efficient, but not delete it entirely, because we've been working with MedEnt directly. So, they recommended that we just hide it. So if they wanted to use it later, we can just unhide it. So that's working out better as well. And then we're currently kind of just figuring out the auto scoring capabilities and working on thresholds for quicker referral and follow-up in the SWIC, kind of these box checking scores, and see how we can automate this as best as possible and really figure out a threshold to make it easy, quick decision. Maybe not easy. I don't know if Dr. Lessig has anything to add here on this particular portion.
Sure, put me on the spot. You said I didn't have to talk, but so I think we are just implementing the SWIC right now. I'm just trying to figure out how we're using it within our visits and how we're interpreting it. And with any screening tool, when you first haven't used it a lot, you sort of have to get used to it and what you can tolerate and what you can't tolerate. I think if anybody has any questions about why we went with the SWIC over the ASQ, that was probably weeks, maybe a couple of months of trying to figure out which one to use. And the reasoning behind that was that the SWIC was more readily available to electronically send to patients. We actually text it to patients before their visit, and then it comes back before their visit. So just trying to figure out how to best efficiently make the process for us so that we have that in our hands before they get into the office. The worst thing would be for them to be filling out paper copies while they're in the office with a toddler running around. So that's sort of where we landed, and it is still a work in progress, is what I will say.
Oh, thank you so much.
You're welcome.
I appreciate that. I keep on using the scrolling bar and it switches the slides. Sorry about that. Next, the billing and coding. So changes are coming from New York State, and payers are removing many screens for the 2023 fee schedule. So we are, exploring this further on our end and with our local insurers and with New York State Medicaid. I know LJ has been, in on a lot of meetings and discovering a lot. I'm not sure if we found anything out last week, LJ, on Medicaid.
I think the main thing is there's not intention to not cover. They're changing some of the codes, and that's what's depending on the service line. So we're trying to get some clarity around that and then send it out to all of you. But I just wanted to say, thank you, because when you reach out with the now this is happening, and our team says what, then we reach out And we get them all wound up, whether it's Excellus or whether it's calling state Medicaid, but it helps because you are on the front line seeing this. So like help us to know what's not right. And we'll continue to advocate. And once we have something that is like, this is fixed, or this is how it's going to be, we'll put it out to everybody. So more to come. But there is not an intent to not reimburse. That's the main thing, the message that I was given. It's just never straightforward, is it?
Thanks,
Okay,
LJ.
Kevin.
Last slide about the HP resources now available. So HP has secured a institutional login for the Bright Futures Toolkit for the entire HP Pediatric network. So we'll be pulling all these resources together for the teams, and you can expect this in an email before next meeting to the practice representative here as well as the practice manager to access these tools. And then also we just wanted to point out the CDC is free milestone tracker, which is really cool, mobile app, and we just wanted to point that out. It's easily accessible, and we just recommend that as well. So in addition to that, we have some coming soon where positive screen follow-up patient handouts, something that our care managers are going to be working on, and hopefully get that to you soon, as well as a one-pager on billing and coding. So like I said, expect an email before next meeting on that. Any questions?
Nice job, Kevin. Thank you
Thanks,
so
LJ.
much. Thanks for all your work on that. So we are right about at the end of our time. I just wanted to give a second to make sure there were no questions for Kevin. All right, I did my quick count to 10. All right, so I think that Liz just asked any luck with the ASQ. You know what? They got such a market there, and they've got such a business. We tried. So, the Bright Futures Toolkit is a great resource, and we wanted to be able to do that for those, some of you have already paid for it, I recognize, but for those who are not using it, wonderful resources for families. It helps work through this, but it does not give you the access to the ASQ. Or, the SWIC is actually a free tool, but it's really costly. And it's also very, it's kind of intensive. It's hard sometimes to get families to complete the whole ASQ without walking them through it. So that's part of the backstory to why we're looking at the SWIC very carefully. And then we'll share our experience with that with you all. So just finishing up, the last thing are two save the dates. So our next meeting, which is in June, on June 7th, we would like to do something different. I don't know about all of you, but I miss seeing your faces. And we want to do a happy hour. No meeting, just come to a happy hour. We're going to shift the time of the meeting. It'll be from 5:30 until 7 on the same date in June. You'll get a new invite. We're anticipating, I think we're going to do Lock 32 on the Pittsford Canal. If we change that, you'll see in your invite, but your assignment is to just come, and our AHP team will be there, and it will be a really nice time to just really get together, talk, visit a little bit. We'll do probably a little more in terms of emailing and updates because we'll be down one meeting, but we felt like this would be a great way to get together. And for folks who would be coming from a distance, I hope it will work for you to be able to come. The incentive of the being together may do it. We recognize the value of Zoom, but it would really be nice to be in person with you all. And then I'm going to turn it over to Jana to just talk about save the date for clinical grand rounds.
I have a very, very quick save the date. I was given 10 minutes and I don't think I talked that much. So save the date, clinical grand rounds is going to be happening again this year in October on the 25th from 5:30 to 7 p.m. Just like last year, we're going to do another virtual format, and we plan on having a pediatric and an adult agenda, as well as a combined initial session there at the beginning. So make sure you put that on your calendars, and as soon as we get more details on speakers, topics, etc., we'll be sharing those out with you. I believe LJ put the pitch out there at last week's update call, but if you do have anything that you would like to see on the agenda in terms of topics, please feel free to share that with myself, Renee, LJ, whoever you find here at AHP, and we'll consider those topics as well. That is my update. 1 minute. I don't know what I could have possibly said for another 9.
I think that was absolutely perfect. Thank you, Jana. And I just want to thank you all for coming tonight and for staying on camera and sharing. It was a really helpful discussion. And I love your song choices. So every time I would read one of them, I'd start thinking about it in my head. So if I was bopping around in my screen, that's why I was already in my head. I was doing your playlist. So I hope you all have a really nice evening. Thank you for coming, and we'll see you in June. We'll really see you in June. All right. Take care. Bye.